A great pleasure to introduce Professor Mayashree from South Africa, and she'll talk about the challenges of African traditional medical practice. Thank you.
Very good morning, ladies and gentlemen. Thank you for having us and hosting us at this 11th Bioethics Roundtable. As we introduced ourselves earlier, I am Mayashree Chinsamy from the Centre of Indigenous Knowledge Systems, based in Durban, South Africa. We fall under the ambit of the National Government Department of Science and Technology. They are co-sponsors with the National Research Foundation. Our mandate at the Centre is to preserve, protect and promote Indigenous knowledge systems in the country. And we do this through research, postgraduate training and knowledge brokerage. And it is our pleasure to be here in our discussion of Indigenous knowledge systems and its relationship with bioethics between and across cultures. Today our paper is on the ethical challenges that face African traditional medicine in South Africa. Traditional medicine, I think the world over, has gone through a long history, and it's also faced a lot of challenges in terms of its recognition, its acceptance, its governance. And I think it's broadly defined, and I think just putting it up here as the sum total of the knowledge, the practices, the skills that are based on theories, experiences and belief systems of cultures across the world. And whether we're able to explain it or not, these alternative healthcare systems are able to maintain our health, and they're also there to prevent or be able to diagnose our health status and improve it as well. The traditional medicine landscape in South Africa can be characterized by both herbal and spiritual healing systems. I think we're all familiar, or we should be familiar with herbal systems. It's fairly ancient, and allopathic medicine has managed to draw from these herbal systems with some of its greatest successes as well. And spiritual healing, as we've heard earlier today, refers to spiritual energies of both the practitioner and the patient, and that is something very central to our African traditional medicine, where you have the spiritual energy of the practitioner being very much present when he is consulting with the patient. If we also go back to the history of traditional medicine, research has shown, and Prof.Mayashree has already alluded to the fact that it is fairly common and predominant in many countries and cultures, and that is not any different in South Africa. And we find that if we consult or we talk to practitioners and patients as well, or the public, they indicate that this is normally their first choice of a healing or healthcare system. And Prof has also mentioned that it's because it's accessible and affordable. But I think the reason that most of our colleagues have indicated is because it is culturally acceptable. So I'd rather see my traditional healer first before I go to the GP. The presentation today argues that while, yes, we find that traditional medicine in South Africa is fairly common, it's a dominant healthcare system, even though it's not formalized or integrated as yet, it still faces, and it shows a lot of community benefits. It still has or faces a lot of challenges, and we make particular reference to the advertising challenges that it faces in its contemporary practice, and we present some of our arguments and expand on them as well. So some of the critical bioethical contestations in African traditional medical practice in South Africa. In our first argument, we show that as anywhere else in the world, with increasing population, there is an increasing demand for healthcare services and products. And unfortunately, again, the situation with conventional allopathic healthcare is that it's not able to meet that demand. So you find unscrupulous, false practitioners who tend to exploit this gap by using, unethical advertising practices to lure and vulnerable patients or persons that are not aware and abuse the patients in the same instance. In our second argument, we find that it was previously believed or considered that because advertising is a concept, it may be a new thing. But by discussing with health practitioners and patients, we find that within these communities in South Africa, advertising is not a new concept, and they still use this rather common way of advertising, which was word of mouth, between themselves, between cultures, and by patients. So you'll get the professionals someone might be a diviner, someone might be a herbalist, and they're able to refer you to another practitioner from another community, from another ethnic group, and you find that sort of cross-referral between cultural groups. And however, we found that because of increased competition, sometimes some of the local health practitioners and or non-local practitioners are using alternative advertising practices just to attract patients to them and to their services as well. In our third argument, we show that the trajectory or the history of traditional medicine in terms of its challenges is more sort of focused on its acceptance, its recognition, its governance. But very little attention has been paid to the unethical practices in terms of advertising in the country. And advertising is very critical. I mean, anyone can tell you that from any sphere of business, whether you're an academic institution, you're a businessman. But we're finding that the unethical practices and its consequences overshadow the merits that an advertising can bring. And because we are so committed in our work with the health practitioners in terms of protecting and preserving Indigenous knowledge systems in the country, we find that this is quite a big challenge affecting them and their practice and the healthcare services that they provide in the country. In our fourth argument, we've got a lot of sub-themes here. We find that these false or unethical false practitioners who practice, or the unethical practices themselves, are more or less common in the urban space compared to the rural space. And in our first thought, in our observation and feedback, we found that it was mainly because these false practitioners are not necessarily related or affiliated to any cultural community in the country. And therefore they're free to make some sort of false claim. There is no traditional authority to, come against them in any way. Their community members are not able to say, but we don't believe that is true. I can go into an urban space and say, I can give you 100% success rate with your female health problems. And there's no one there to back me up or to say that, no, this lady is talking nonsense, as Prof. Mayashree mentioned earlier. So that is, I think, as a regulatory system, and traditional regulatory system is not present in an urban space, so they are able to exploit that situation. In our second and third arguments, I think we make reference to the urban space in terms of societal challenges, where you have consumers on two ends of the spectrum, and then across that spectrum, those that are fairly under-resourced, find themselves in a desperate situation, facing a number of societal challenges, such as poverty or unemployment, and you find that they may not have access or the resources to have access to conventional medicine and their services, so they tend to resort to these alternative healthcare professionals who would say, we can help you at half the price or at 50% off, and of course you end up with sometimes worse off than you started. You also have educated persons perhaps who are not under-resourced. They have the resources, they're fairly well-to-do, but they have an affiliation, a strong cultural value system that they still maintain in the urban area. And then they still look for practitioners to assist them with their health status. And again, we said health is not necessarily because I'm sick or I have the flu. I might be stressed at work. I might be, I might be a politician and I'm about to go in for elections. So my health status would require me going to, consult with my health practitioner. And if someone is punting or advertising that they can, ensure my success in the election, of course I'm going to go there and pay my hundreds and thousands and millions in exchange for this proposed success. I also wanted to allude, I think Prof. Mayashree in his opening slide mentioned that technology has been a catalyst, and we find that some of these false practitioners who have engage in unethical practice now use technology to increase their accessibility as well. So if I am in an urban space, I might have access to the internet, I might have my cell phone, I will receive an email, I have access to their websites, I can receive SMSs, WhatsApp messages. So I'm inundated with these advertising tactics and strategies. So at one minute in time, perhaps I will decide, I will go to this practitioner. So that brings me to the issue of regulation in South Africa. We have our Health Professions Council as well as our Allied Health Professions Council, which is meant to regulate healthcare practitioners in the country. However, you'd find quite ironically that African traditional health practitioners, both locally and from outside the country or from the continent, are not regulated under any of these acts that come out from these councils, and therefore it's a major gap in the country in terms of regulation of traditional medicine and these practitioners. So you'll find I've highlighted, sorry, but not very clear in the second. There's a page there on advertising under the ethics and codes of conduct for health practitioners. Under the allied health practitioners, we have Chinese medicine that is covered, Ayurvedic medicine that's covered, homeopathy, but not African traditional medicine, despite the fact that we are on the African continent. I just thought maybe perhaps to share some of the examples and the terminology under which you would experience an advertising moral wrong. Misinformation. I can come up one day and say, I am Professor Dr. King or Queen Mayashree, and people will become attracted to that because they see me as a sense or a sign of authority in a certain field, and they will not, think that I'm false. There's also exaggerated competence, saying that I'm able to cure you of HIV or cure your diabetes, and no one is there to say, yes, I actually do have the knowledge or the competence to do that or to achieve that. A false guarantee saying that within 5 days your problem will be gone, 100% gone, permanent results. And then there's false testimonials. When you trace back some of the testimonials that will appear on an advert, the person either doesn't exist or they're in some place that you'll not have access to, so it's someone in an area that's too far away. And there's also the use of claiming that the particular medicine is sourced from a certain area or prominent landmarks or sacred spaces, just again to play on vulnerability, to instill some sort of confidence in the patient that this is a legitimate medicine. I've used a few examples just to highlight this, and this is just one format or platform in which medicine is advertised in the country and in the region at large. So you can get a flyer at the traffic light, you stop with your car, you get a flyer, it's stuck on walls. So this is Prof. Hassan, not this Prof. Hassan. Yes, there's again the use of a title. He says that he is qualified at the University of Zanzibar. I cannot again, prove that he is from there. Sorry, Prof. And then there's a testimonial at the top that reads, he is highly rated man in the world who has helped many to fulfill their life's purpose and destiny with the help of spiritual powers. And he has the knowledge that he has gained from the University of Zanzibar. And he promises you a lot of success. And he is readily available on a cell phone. And he can, if you even try to phone and then you close the call, you will always get an SMS back saying we are there to help you with any of your problems. We have, as a second example, again, in South Africa, our healthcare practitioners and professionals are divided as diviners, as herbalists, surgeons, birth attendants, and midwives. And the image that they've used on this particular flyer is on the top left. It's a lady. She's a sangoma. It's meant to be a sangoma, a diviner, someone that can speak with your ancestors. So again, this is now a way to appeal to the local population to show that we are legitimate. They've again used the title of prof and doctor. And you'll also notice on this flyer that they've used a number of languages that are local in South Africa, and that is again to appeal and attract a range of members of the population. And they make claims of an African science. And then the last example I've used here, this is a female specialist, and she's able to assist you within 5 days, period. And again, she's able to appeal to all whites, blacks, coloreds, Indians, across the racial and ethnic groups. And the image that she has here is of a map to show you where she's located. And you'd ask yourself, if she's so widely or so readily available, you can find her so easily, why is she not being taken to task? And I think that I've already alluded to is the fact that there's a lack of regulation in the country in this regard. So, as an example, our National Government of Science and Technology are currently developing a statutory body in the field of African traditional medicine on accreditation and certification of the health practitioners, or who we call Indigenous knowledge holders. And this is a body of themselves, together with other stakeholders, and it's there to regulate themselves and to protect the profession. Because when we engage with the traditional health practitioners, we have them all in the room, and they themselves are first to say that we are aware of those among us who are false, but we do not have law and regulation that is able to help us to protect our profession, because it puts them in a bad light. I mean, they're open about that. We're also recommending that there be promotion of knowledge and awareness amongst the public. And again, in our higher education institutions, we do not have African traditional medicine as part of our curriculum. And I think the introduction of that in whatever format, but throughout medical practice, would at least promote that knowledge and awareness amongst the practitioners, allopathic practitioners, and the patients that they engage with as well. I think we are just repeating a little bit of Prof. Mesa and what Prof. Kaya and I normally talk about, in the sense that if we consider African traditional medicine as from its indigenous knowledge perspective, we would find that it is a holistic knowledge system, and it looks at ethics and moral conduct in its holistic form, from ways of protecting the environment, as well as ways of protecting and your moral obligation to your patient, to the environment from which you source your medicines, and the spiritual energies that you use to guide their medicine. So I think I'll just take us down to the last point, where we say in South Africa we are aiming to protect traditional medicine. But at the same time, we should take cognizance of the fact that we have many healthcare systems operating in the area, simply because of the different cultural groups and ethnic groups that we have. So cultural dialogue will be imperative to provide that cultural understanding of what is morality, what is ethics, what is bioethics, are they different, are they the same among our cultures. And just to give you an idea of what we do. This was recently, I think 2 weeks ago. It's our ongoing introduction with our healthcare practitioners. These are the African health practitioners. Again, in South Africa, we don't just have one African ethnic group. We have a multitude of ethnic groups, so we've brought them down together. And we've taken them through our laboratories just to share with them what it is, what is the process. And they've shared with us some of their ethical concerns, that what is clinical trials, they have a different approach to clinical trials and the testing of their medical products on animals. They're happy to sit with us in our lectures and engage with us. Here are some of them. You'll see that they're male and female, different age groups, and they are accredited amongst themselves and by their communities as well. So I think I will leave it there and hope for you. Thank you.
Thank you very much, Maya. So the discussant is Professor Chutatu, okay, and you will lead the discussion. Thank you.
Can I have the microphone, please?
Nice.
Thank you very much for your presentation. Any questions? Please, go ahead. Veda?
I think your presentation was very much within the area of medical ethics, because you have these professionals that claim, for example, to be able to treat somebody while they're not qualified, or while what they promise cannot be actually achieved. For example, you mentioned sometimes they talk about a treatment that they want to do, but they are not expert enough to do it. But what I want to say is there are limits for a lot of these treatments. For example, HIV cannot be treated no matter how expert you are. Or there was a large meta-analysis of homeopathy that said, it's no better than placebo. So if you define what are the limits, you shouldn't try to treat cancer with a herbal medicine. You shouldn't do that. And I think that's a big issue. I had a student from Africa who was a medical doctor. He was from Malawi, and he had become HIV positive, and he refused to take medical treatment, saying that he would rely on herbal treatment. And I was shocked to see that, So I think we need to teach the limits. Serious disease requires evidence-based, medicine.
Okay, I'll give Prof a chance in 2 seconds. All right, maybe the presentation, just to give an idea. African traditional medicine and the practitioners that we work with are not the ones that are making these claims. These claims are being made by false practitioners, people that are not being accepted within their communities, and so that is the first part. The second point is when you make reference to, say, for example, HIV and the use of herbal medicine or cancers, and the use of herbal medicines to deal with this particular, and then we must think about limits regarding the treatment of these diseases. It brings us back to the philosophy of African traditional medicine. And in our discussion and engagement with practitioners, they give us a very different understanding and concept of healing, of medicine, and when you say this is just limited to just medical ethics, we say that it expands to social, other areas of living, whether it be your social interaction, your social construct, the environment. So a health practitioner will tell you, if I go and harm this plant, I cut it off, this is a tree, I've demolished this tree in order to take some sort of herbal medicine to treat a patient. The patient will not be cured, will not be healed, will not be treated because I've hurt or harmed this tree. And they do not use words like curing. They use preventative medicine, and they're able to treat. So in terms of limitations, limits, they have all of those incorporated in their practice. They are very much aware of how medicine, then because it's an ancient medical practice, one. And you'd find if the argument is that these traditional medicines can kill people because people are not aware, they themselves say yes, we believe that because there are false practitioners that are misleading people. But us who are authentic, legitimate practitioners, where we know based on experience how the medicine has evolved and how the circumstances and situations in the country have evolved, we've adapted, we've evolved, and we know that the medicine is there to treat and or prevent. So there are many rituals and ceremonies that they would conduct in order to prevent a certain disease state. But of course, HIV and things are prominent and prevalent in the country. And it's because of a lot of social issues that people now face. And they are finding new ways of treating, again, knowing that there's a limit. They cannot say, but they do not recognize HIV. That's another topic for discussion at another day. But they do not recognize HIV as HIV. They don't call it HIV, but in Zulu. You know, they call it something else, and it's based on their understanding of the disease. They don't call cancer by cancer in Zulu. They call it by something else, and it's based on the affliction on the body, based on their philosophy, based on their understanding. And again, that knowledge doesn't come from him as an individual. It also comes from their ancestral in spirits. And they'll tell you, two people will have the same disease, certain cancer. But their situation, their scenario, and how they came to be in this world in the first place, and their current scenario and circumstances in their life, and where their future is headed based on their ancestral spirits, will tell you that the cancer is not necessarily the same, and their treatment may not necessarily be the same. So those are a lot of other sorts of discussions. Us just, reducing HIV to HIV based on our current and allopathic understanding means that we are removing or reducing and ignoring their understanding and philosophy behind the disease state. I give Prof quickly some idea.
Yeah, I think I just want to build on what Mayashree says. I mean, the question of that's why the issue of culture is very important in the sense that, and language, because the way you say that, there is a limit to particular diseases in terms of cure or treatment, that is a cultural understanding. Most of the traditional healers, I don't know in other countries, but in Africa, they have that idea that the concept of HIV/AIDS does not exist in the African interpretation, and it's not a new thing. That the disease or the symptoms of it have been existing for years. This question of calling HIV/AIDS is a Western concept, and the understanding that it cannot be treated is also a Western concept. And most of the majority of the people live in a cultural that environment. So the way you put it is the way you understand it, not the way people understand it. And that's why these cultural dialogues of bridging gaps, as they recall it, are very important, because you bring the way you understand it. I don't know where you are trained from, but the way they grow up in society, the way they interact, and some people take advantage of that to advertise the way they want and make money out of it.
Thank you. Any more questions? Yes. Oh, yeah.
Yeah, I would like to ask you a question. In most of the countries in the world and different cultures, they all adopt what you call traditional medicine. It need not necessarily be what you call cheating the people. But my impression from what you said is, in most of the countries where traditional medicines are being practiced, it is not for just HIV/AIDS or for cancer when it reaches the maximum stage, but when it is only a beginning stage, viral fever and throat infection or heart infection. See, then it's only traditional medicine which cures the people. Even HIV, if it is going to be only, say, what you call some sexual diseases at the beginning stage, and even if it is going to be cancer, if it is going to be at the beginning stage, if they detect it and if they are going to give what you call herbal medicines, I think that is good in my opinion, because as far as India is concerned, and here we have one lady who is a Siddha Ayurvedic and Siddha medical doctor. We believe in such doctors because they are able to cure even the viral fever, even the dengue fever, whatever, or infection of all types of organs. They are able to cure with the traditional medicine.
Yeah, it's true.
You don't allow any disease to go to the maximum.
Yeah.
Only then you have to depend on allopathy. Because she gave us an interview in TV when she was telling that you start with the herbal medicine and then you combine it with allopathy. Don't depend on allopathy, don't depend on the Western medicine directly. We all appreciated the way that she gave. But from what you say, you are criticizing your own country.
No, I think that is a very good criticism, and I think that is what we're trying to explain, that the challenges that face African traditional medicine in the country is this unethical advertising the unethical advertising, the false practitioners in the country are what are creating an impression, are creating the scenario, creating that, a perspective that traditional medicine is bad in South Africa, when actually the legitimate practitioners are now suffering because people are just being flooded with this nonsense, and we have this impression that things are bad. Just one other point, for example, if I say two people go to take a blood test, and our results get mixed up, and then I get my results saying, oh, I am HIV. I will be stressed, I will get sick.
Yeah.
I will get sick. And the person who's gone home with his results, I am healthy, he will be fine. But actually our results were mixed. And it is because of that mental condition sometimes. And that's why you're saying there's a sense of, what did you say, placebo effect. It's not a placebo effect. It is sometimes just sitting and talking to your practitioner, your consult, when you consult, you feel better. You take the medicine and you believe, it is a belief that I am going to feel better. And then that is how you heal. And our African traditional health practitioners always tell you, prevention, prevention, prevention. They try to prevent from daily life, daily living, food that you eat, rituals. When you are a baby, you must do this. When you are 6 years old, we just give you the medicine. It doesn't mean just because you're sick, you should be taking medicine. You are taking medicine daily, almost, through food, through rituals, through ceremonies, and so on and so forth. So our presentation is to show that traditional medicine is facing a challenge because of false practitioners and false claims, when actually, in fact, the real legitimate practitioners are being impacted on negatively. All right.
No, it's okay.
Okay.
One more question?
Yeah.
Yes, Professor.
Thank you very much for your presentation. I see there is always a conflict between the traditional medical practitioner and the Western practitioner or the allopathy practitioners. So how actually you are trying to resolve this? Because most of the time the Western medical practitioners, they are not ready to accept it. Though there is a remedy which is very much available in traditional methods. So how do you try to resolve that? And secondly, I want to know whether, because there is always a cultural bond between Tamil Nadu and South Africa, whether you have been very much influenced by our traditional methods like Siddha or Ayurvedic, this thing like that.
Okay. Two points. So the first one was how do we bring conventional allopathic medicine and traditional medicine together? And I think that is perhaps why I gave the example of our department, National Department of Science and Technology, as well as the government at large. We've started to integrate and recognize, the first step is to recognize African traditional medicine exists as an alternative healthcare system. And then now is the different government departments trying to bring it under regulation to develop statutory bodies. But we didn't want to do it from a top down. I think the idea is to do it from bottom up. So that statutory body is majority made up of the health practitioners themselves. And so we have these health practitioners that have their own schools, they have their own nurseries, their own pharmacies. So to have those accredited and certified, so if anyone goes through that school, you come out with a qualifications level that you can go and enter in any other higher education institution. But that's still at its infancy stage, but that is, we're starting to do it slowly so that we get it right the first time. But it is these healthcare practitioners themselves that are able to tell you, I know that that lady there, she claims to be a reproductive specialist, a mental health specialist. We do not know of her because they accredit themselves. You first level, second level, third level, fourth level, how many years of experience, how many patients you've had, how many referrals you've had. So they're able to accredit themselves in that way. And then certification is of course based on the conventional or formal system as well. So that relationship, I will give Prof, he'll give you more insight. He's been part of that, that process. And then the part about influence of other healthcare systems in South Africa, like I said, the Allied Health Professions Council covers Chinese medicine, Ayurvedic medicine, Sunni, Siddha medicine. I think they've worked a lot with Ayush Institute as well. We have a lot of people, postdoctoral researchers from the subcontinent as well that are in South Africa at higher education institutions that are doing research on not African traditional medicine but on Ayurvedic medicine or other forms of Indian medicine. So yeah, I think, and it's about having that cross-cultural. We have South Africans doing medicine, other healthcare systems, and the other way around. We have Indian people from India doing African traditional medicine research. So that integration is there. I just give Prof 2 minutes quickly.
Yeah, I think another important thing, for a long time there's been a suspicion between the traditional medicine and some of the pharmaceutical industry and the conventional medicine. But what we've done over the years is to bring the two groups together with a number of meetings whereby we brought traditional healers from different cultures and the pharmaceutical industry and students from medicine, whatever, coming together. For instance, last year we brought the University of Nottingham, the School of Pharmacy. We went there and they came, but before we went to Nottingham, we had a meeting with our traditional healers to air their own concerns. And they met with their own researchers from pharmacy, from the medical school. And when we went to Nottingham, we went there to present their own concern. When School of Pharmacy came, they also met with the traditional healers, they also met with the researchers, and they even went to the school Mayashree is talking about, where we've got the practitioners who have a school teaching traditional herbalism, they've got nurseries, and they've got pharmacy. So we are bringing dialogue. What she showed you, for instance, there was to bring traditional healers to see the laboratories. Most of them had never been in a lab. So they went to the laboratory to see how research in HIV, in tuberculosis is done, interacting with the students, researchers, and interacting with researchers. So there was they're coming together to remove the suspicion which they had in the old days. And there are so many activities. For instance, we are trying to bring the lab into the community and the community into the lab, whereby those who are running those schools of herbalism, they would like their medicines to be affirmed through research in the lab. So there is a slow process whereby the two knowledge systems come together and thus understand and find areas where they can do research and promote public health care together. I think you stop there. Yeah.
Thank you very much. Professor Dario? Yes.
Thank you. I have a question.
Traditional medicine could be very good if we didn't have this globalization. Now, diseases that never existed in Africa now have started to appear there. I remember there was a time, apparently there was no appendicitis. Nobody would have appendicitis in Africa. So many diseases, emerging diseases are now. So there is a limit. And what I said was that this is not my opinion. This is science which studies and approves or disapproves a certain treatment as good enough to be recommended. It's not my opinion. It's not that the culture and I have different opinions. I don't have any opinion here. It's about whether we feel responsible to use scientific evidence to give hope to people, to make claims, and this is a very basic medical ethics question. So I have no opinion on this. It's up to you, and I'm happy I'm not working in this area.
Okay. Well, I think it's a matter of opinions and choice for one to choose. Yes. And any more questions? I think it's about time for us to have a break.
Yeah, thank you very much. So
Yeah.
I guess every knowledge system and every knowledge paradigm, we have some assumptions. So again, we need to qualify what sort of science we're following. We're following Indian traditional science or African traditional science or modern Western science or social science or genetic science. That you're talking from the
Medical science.
Yeah.
But medical science, Indian medicine science, or African medical science, or Amazonian science, Chinese science. So again, the concept of science is so broad, we need to get down to our epistemological foundations, I think. Okay.
Yeah, I think the most important thing from our indigenous knowledge perspective is what the professor from India said. I mean, most of our traditional, those who are not exploiting the market because of desperation, have put in emphasis that there are so many diseases which could have been prevented if they were diagnosed from the beginning. And that's why we're also working with them to ensure that if there are any herbs, if there are any spiritual aspect we can be done from the time of conception of a child up to the time, each saying, if you follow the whole rite of passage, we're trying to work with them to identify certain preventative measures, including herbal resources which can be used to ensure that certain diseases which appear in the old age, which have gone too far, can be prevented from the time. And that is also one aspect when we went to the School of Nottingham of Pharmacy. People were excited that we need to put emphasis on the question of prevention from an early age so that diseases don't escalate to the point whereby they become too much, and also there are charlatans, as Mayashree pointed out, who exploit that to make money out of it.